Welcome to the Advanced Practice Life and Emergency Medicine Ultrasound Rounds. This video is designed to provide you an approach to rapid ultrasound assessment of the patient presenting with undifferentiated shock. I won't get into the basics of ultrasound during this talk, as I have other talks dedicated to the beginning advanced practice emergency medicine sonographer. But this talk is dedicated to the patient that arrives in your shop hypotensive and demonstrating signs of shock. As we all know, shock comes in several different forms and requires immediate recognition and intervention by the emergency provider. For your quick review, clinical manifestations of when to start suspecting shock are hypotension, tachycardia, oliguria, altered mental status, tachypnea, and cool, clammy, cyanotic skin, just to name a few. So the notion of sonographic evaluation of the undifferentiated shock patient was first being discussed around the early 2000s. There are many articles now having studied rapid sonography in shock patients. One of the first was in 2004 by Jones et al., whose study showed a quicker time to final diagnosis with early ultrasound in ED patients with hypotension. So let's get to the actual exam. As you have suspected by now, RUSH is an acronym standing for Rapid Ultrasound for Shock and Hypotension. It is a structured protocol for point-of-care ultrasound performed at the bedside of a patient presenting in shock with unknown etiology. It looks a lot like the FAST or EFAST exam performed in traumatically injured shock patients, but is slightly longer and more detailed with aims to differentiate between hypovolemic, cardiogenic, obstructive, or distributive shock in the medical shock patient. So how do we know where to begin? Fortunately, people far smarter than I have come up with the mnemonic HI-MAP, and this will be our approach. Let's start with the heart. When we're evaluating the heart, here we'll start with the parasternal long axis view, looking specifically for a pericardial effusion with tamponade, right ventricular failure, which may indicate a pulmonary embolism or severe MI of the RV, and evaluation of the left ventricle. Of note, the LV can be assessed in the parasternal long and the four-chamber apical views. So here's an example of a normal heart in the parasternal long axis view. Notice good contractility. This is a qualitative study, of course. We're not measuring anything such as ejection fraction or anything like that. Note the pericardium shows up as a hyperechoic line around the heart. Also note the valves opening and closing at appropriate times and fully closing. Here's one of the pathologic features we are trying to identify in the RUSH exam. This is pericardial tamponade. We can assess for fluid in the pericardial space, which, like most fluid, follows gravity and therefore will accumulate posterior to the LV. We can also look at the right atrium and right ventricle for any signs of collapse during diastole. If this is visualized, then the cause of shock is likely tamponade. In the four-chamber apical view, we can evaluate the RV for any signs of enlargement. This is a normal RV in the four-chamber apical view. Now compare this to an enlarged RV with RV failure. In the shock patient, it must be considered to be either a large RV infarct or more likely a massive PE. From a qualitative standpoint, the RV should be smaller than the size of the LV and should raise concern if the RV is greater than the size of the LV. Of note, if one observes the RV apex with an inward motility, this can be highly specific for a PE and is referred to as McConnell's sign. Moving on to the evaluation of the LV, here you will be looking in the parasternal long view, and here you want to qualitatively evaluate, meaning just evaluate visually, the size of the LV chamber between systole and diastole. If there is not a significant difference in chamber size between systole and diastole, we can say that the LV function is decreased, which may indicate a cardiogenic etiology. We also want to quickly evaluate the LV for hyperdynamic contractility. This is done in the peristernal long view. Here, you're evaluating the LV walls between systole and diastole, and if they are coming together or coming close together, then we can say that this is a hyperdynamic heart and may indicate hypovolemia or acute blood loss, or can even occur in septic shock. Next, we move on to our I in the high map. This refers to the IVC, as you may have guessed. Now, there has been some debate regarding the evaluation of the IVC and volume status, with more improved ways of truly assessing volume status. For our purposes, we will evaluate the IVC to determine if the patient will tolerate an IV fluid bolus. We locate the IVC just subxiphoid and about 2 centimeters to the patient's right, and our probe is in the long axis view. It is really helpful if you can locate the IVC as it approaches the RA. Here we are looking for dynamic changes between inspiration and expiration. Based on a couple of studies by Adler et al. And Kircher et al., an IVC diameter of 1.5 centimeters or smaller with complete inspiratory collapse, that is, on inspiration the walls of the IVC collapse together, this is associated with a good response to volume boluses and consequently a low CVP. Now, vice versa, if we see a plump IVC greater than 2 to 3 centimeters with no or very minimal inspiratory collapse, this can suggest an elevated CVP, and fluid boluses are unlikely to help your patient. We should consider other methods to improve cardiac output and raise their MAP, such as inotropes. Now, it should be noted that the previous discussion of the IVC is in the setting of a spontaneously breathing patient, not a mechanically ventilated patient. In mechanically ventilated patients, the IVC becomes enlarged and therefore needs to be evaluated for variation with the patient completely sedated and not taking any of their own breaths. Next is our M in high map, which stands for Morrison's pouch, accompanied by the rest of the fast views. These include Morrison's pouch, which is the hepatosplenoid recess, the splenorenal recess, and the suprapubic view, evaluating for any free fluid, which could be a number of etiologies causing bleeding in the intra-abdominal compartment. A quick view while performing the fast on the abdomen of the diaphragm-lung interface can also aid in evaluation of any fluid in the thoracic space. Now we can move on to the A in high map, which is the aorta. The abdominal aorta can be quickly evaluated with the ultrasound probe in the transverse view, beginning at the subxiphoid space and scanning down to the umbilicus. This will get you the suprarenal, infrarenal views and the bifurcation into the iliacs. If the aorta is measuring greater than 5 centimeters in diameter, that's an AP measurement, then one should highly suspect a ruptured AAA. Now, it may make you nervous to just presume a diagnosis based off of a measurement you have just taken, but if the rest of your rush exam is not yielding much and you have a hypotensive crashing patient, then pulling out all of the stops is okay to do to potentially save a patient's life. You can always call off the troops if this ends up being wrong. Lastly, our P in high map stands for, you guessed it, pneumothorax. To evaluate for a pneumothorax, we'll take the high-frequency probe, that's a linear probe, or some call it the vascular probe, and scan the anterior chest, mid-clavicular, on both sides, evaluating for lung sliding. We can also use M mode, or also called motion mode, to evaluate the seashore sign versus the stratosphere or barcode sign, which is indicative of a pneumothorax. So there we have our high MAP mnemonic to give us a protocoled approach to using ultrasound in the rapid assessment of our medical hypotensive and shock patients. Interestingly, as I'm recording this, there was just a recent randomized trial that came out in September, which looked at over 250 patients in the ED setting with undifferentiated hypotension and found no difference in 30-day survival, CT scanning rate, inotrope or IV fluid use, or length of stay. These are obviously interesting findings, and I'm sure there will be discussion coming down the pipeline of this study. Of course, 250 patients is a small number and probably won't change many people's approach to using the Rush exam at this point. All right, that should do it for now. Thanks for listening, and remember, the only way you get better is to keep scanning.